Good evening, and this is case study 1 for group 12, adult female with anxiety and depression. Our team members are David Appleby, Dusty Best, Molly Gorey, Amanda Hancock, Simone Noble, Lexis Perry, and Tasha Price. My name is Amanda Hancock, and I also have on the call Dusty Best.
Hello.
And Tasha Price.
Hey there.
We'll go ahead and begin with our case problem history. A female patient is diagnosed depressive patient who needs to restart on her medications. Her major symptoms are lack of interest in her usual activities and some anxiety associated with her workplace stress, but she denies issues of sleep disturbance and overeating. These were issues when she was diagnosed as depressed 2 years ago. She received a selective serotonin reuptake inhibitor medication, Paxil, at the time. She is reluctant to take it again because she had an onset syndrome that she had not been warned about. She admits she did not do very well on it because the doctor took a slow and watchful approach to altering her medications. She also had a rough time when she decided to stop taking it after 2 years. She read an article that said timelines for depression medication therapy have changed, and she has some questions about this. Now I will hand it over to Dusty Best, who will discuss the disease process and management.
Good evening. This is Dusty. We're going to discuss the disease process. In order for the patient to be diagnosed with depression, the patient must experience depressed mood or anhedonia, which is lack of desired activities they had previously done, for at least 2 weeks with 4 additional symptoms present. The patient may have depressed mood, feelings of worthlessness, and guilt. In contrast, anxiety is a feeling of excessive worry, unease, panic, or nervousness, typically triggered by an event. In the diagnosis of depression, all potential medical disorders must initially be ruled out as the primary cause of the patient's symptoms before the diagnosis of psychiatric disorder. 2 screenings used include the Patient Health Questionnaire and the Center for Epidemiologic Studies Depressed Scale. SSRIs are used in the treatment of depression. Their mechanism of action is that they block the transport mechanism that returns unbound 5-HT into the presynaptic neuron that terminate the transmission of the message carried by the receptor. More 5-HT is available to bind to the prosynaptic serotonin receptor and decrease the symptoms of depression and anxiety. Our purpose in order to help the patients will be to restart the patient on a new medication, control the symptoms of anxiety, and regain interest. Our goal of our treatment is that our patient will adjust and tolerate the new medication. Trouble with anxiety and depression will subside without harm, and the patient will be able to return to the enjoyment of normal activities. Moving on to the diagnostic management section. In order to accomplish our goals, we must first accurately diagnose the patient's condition. This starts with a thorough physical exam and ordering labs to identify any medical problems that could contribute to or mimic depression, such as hypothyroidism, anemia, HIV, hepatitis, STDs, renal impairment, and cancers. In addition, patients must have 1 depressed mood for at least 2 weeks and exhibit at least 4 additional symptoms: changes in weight, sleep patterns that are different from a baseline, fatigue that is new and not due to a medical condition, feelings of worthlessness or guilt that occur nearly every day. Can't diagnose within 2 weeks of losing a loved one due to the bereavement exclusions. Determine severity, including psychosis and catatonia. Assess their suicide risk. Review the patient's current medications and substance abuse. Review patient's current stress and life situations, and consider support systems of family situation and personal strengths. Team member Tasha Price will speak to you about management, including pharmacological therapies.
Hi guys, it's Tasha. I'm going to talk to you about management of depression. So psychotherapy or pharmacotherapy alone are in combination. Psychotherapy, including cognitive, behavioral, or interpersonal therapy. Identify negative beliefs and behaviors and replace them. Find a better way to cope and solve problems. Develop ability to tolerate and accept distress using healthier behaviors. Exercise is recommended to work in conjunction with medication as well as going outdoors. You can also increase interest in previous daily activities. So drugs are SSRIs. They're safer, less side effects. Celexa, and Paxil. So Paxil, starting dose, they start at 20 milligrams. Older patients or those with sensitivities can be started with 10 milligrams in the morning, increasing doses by 10 to 20 milligrams a day every 1 to 4 weeks. Doses should not exceed 50 milligrams per day, available in liquid and enteric-coated form. Controlled release form is started at 25 milligrams a day with a max of 75 milligrams a day. Therapeutic range is 30 to 100 ng over ml. Citalopram, starting dose is 20 milligrams. Older patients or those with sensitivities can be started at 10 milligrams in the morning, increased dose by 10 to 20 milligrams a day every 1 to 4 weeks. The therapeutic range is 50 to 110. There are SNRIs, including Cymbalta, Effexor, generally used as a second line of if your SSRI isn't working alone. There are atypical antidepressants, including Wellbutrin, Remeron, and Trazodone, as well as others. Another form is MAOIs, including Nardil and Parnate, which may be prescribed if other medications have not worked. So non-drugs, non-pharmacotherapy includes cognitive behavioral therapy, teaching patient new skills to take control of their symptoms. Counseling in groups can also be helpful, so the patient has someone to talk to and vent to. Another activity is to plan family time or vacations, encouraged to acquire a new hobby. The patient can also try acupuncture or supplements, including St. John's wort, but they must be very careful with the supplement as it interacts with many medications. In more severe cases, you can try repetitive transcranial magnetic stimulation for those not getting better with all other therapies. Electroconvulsive therapy is effective for 64 to 87% of patients with severe major depression. So we'll go over SSRIs. We kind of talked about the Paxil and the increase in those, as well as the SNRIs and atypical, as well as the MAOIs. So now I'm going to pass it back to Amanda to wrap everything up.
So our key points and conclusions are to ensure that the correct dosages are being given to the patient, that they're monitored and tapered off correctly by the prescribing provider, that patient education is very important with these cases. Extra care must be taken to educate patients on signs and symptoms to watch for and when to report anything out of the ordinary to the provider. We must educate the patient on side effects of medications so that they know what to expect and maintain compliance. For SSRIs, a patient may experience diarrhea, dizziness, nervousness, nausea, sexual dysfunction, sleep disturbances, and changes in appetite, but the majority of these symptoms should subside over time. For SNRIs, insomnia and elevated blood pressure are possible. For the atypical antidepressants, a patient may experience dry mouth, tremor, sweating, or increased anxiety. And for the MAOIs, sudden elevation in pulse and blood pressure can occur in patients. And these patients that are on these also have to undergo strict diet changes, the restriction of tyramine containing foods such as aged meats and cheeses and all fermented products. And again, those are a last line of treatment. We also need to encourage our patients to practice pharmacological as well as non-pharmacological measures, such as exercise and cognitive behavioral therapy. Incorporate a multidisciplinary team to round out the treatment plan and provide maximum benefit to the patient. Some things to note are depression and anxiety is a mental disorder, and they're quite common in practice. So as providers, we should be screening all of our patients, and we must maintain familiarity with diagnostic criteria, as well as the latest evidence-based practice regarding pharmacologic and non-pharmacologic approaches. SSRIs are generally the drug of choice to begin with management. However, these medications may exacerbate depression and anxiety at first, so we must always watch for side effects We must always watch for risk of suicide and stress to the patient the need to communicate with care providers. And we need to watch for any changes of behavior in our patients and intervene as indicated. If the things that we're trying aren't working within 2 months, we need to consider a mental health referral. So some questions for the audience to consider are, at what point should one seek reevaluation of prescribed medication? What adverse reactions should be reported? What are some non-pharmacological ways to aid in pharmacological therapy? And also name the 2 diagnostic screenings for depression. Thank you for listening to our presentation. If you have any questions, please direct them to one of our team members. Thank you.